Oh, hi, Gavin. It's Barry Casson. We haven't met before.
Hi, Dr. Casson. How are you?
I'm good. Is your, I can see it's a great topic. Are you working with anyone specifically that's going to be introducing you, or do you want me to do that? Or it's not up to you, but is it Adam Peets, or who's been your supervisor?
No, Sandy mentioned that you would potentially do it, and
Sure.
I don't think there's anyone else planning on it. So if you're happy,
Oh,
that would
sure.
be excellent.
Yeah, and Gavin, just background. Where did you do your where'd you do your core training?
Undergrad at UBC, medicine at UBC, surgery at Dal, and then ICU here at UBC.
Okay, great. Okay, well, this is really this is very timely.
Isn't it?
Yeah, no, it's. I hope that. Yeah, it's very timely. So we now was it a full hour talk, Gavin?
It's probably going to be between 45 and 50 minutes. We've got some time for questions and waiting people to linger in, for sure.
That's great. That's great. All right, and where are you in your training? Just about completed?
Yeah, another 3 weeks, I guess.
And then what?
Oh, who knows? We're working on it. I mean, it's a process. I'm really hoping for a permanent position somewhere in the city here.
Sure. Well, I hope that's so, and this, I suppose, will go some way into securing that. But no pressure, right? No pressure.
Yeah, of course not.
Okay, we're going to give it one more minute.
Sounds great.
So you actually did surgery as your entrance into critical care?
Yeah, that's right. So general surgery is my base specialty, and I've been here doing combined critical care and acute care surgery fellowship.
Right. Okay. Boy, oh boy. That's a really important component. So I think we'll give it a few more minutes.
Yeah, that's totally fine.
Morning, Stefan. Well, it is 12 o'clock. Welcome to Grand Rounds. Today's Grand Rounds topic is certainly applicable to all of us and to our patients. And the topic is, who is an ICU candidate? Really, I'm sure it changes from week to week and year to year. Today's presenter is Dr. Gavin Tansley, who I've just met, and so I'm just communicating what he's told me, but I'm really excited about his talk. Dr. Tansley is currently a critical care fellow, having completed his surgical training in Dalhousie and in general surgery, and his medical school at UBC. So I think with that introduction, which is brief, but I think we're all interested in who is an ICU candidate. Gavin.
Thanks so much, Dr. Casson. And it really is an absolute pleasure to be able to talk to you guys today. I feel like we don't get the opportunity to interact nearly as much as I'd like. But it's also a very intimidating feat for a surgeon to sit and talk to a group of internists. It's stuff nightmares can be made of for me. But that being said, fairly early in my training, I learned a trick for doing that and not embarrassing myself is to pick a topic that nobody knows the right answer to. Spoiler alert. So although the topic for this talk is largely out of self-preservation, it is also an area where our worlds intertwine. Every day, we need to work together to identify appropriate patients to be moved to a ICU setting. Similarly, every day, we need to work together to agree on which patients are stable enough to ultimately be moved out of the ICU. So I think it's really important that we have a framework at least, or at least some principles with which we can leverage to at least be able to make those decisions consistently. And unfortunately, despite decades of work on the topic, it's still something that is actively debated. But nonetheless, there's some things that we can talk about. And so I wanted to touch on three major areas. The first is I wanted to describe some of the costs of providing ICU care and some of the trends in the resource utilization of ICU, really to illustrate which or how constrained that resource really is in our Canadian context. I want to discuss some of the factors that ultimately influence our decisions to utilize ICU resources or not for our patients. And then finally, review some of the data that informs how we can prognosticate these patients, but more importantly, how we can or potentially cannot use that data to make admission decisions. But complicating an understanding of ICU resourcing right from the start is that nobody really knows how much of the resource we need. In Canada, we have about 13 ICU beds per 100,000 people. But that's not constant across the globe. And in fact, in many Western European contexts, mature health systems like ours, they get away with substantially fewer ICU beds. In the US, however, they've got substantially more. And I think that's not entirely surprising. That's probably driven by how these beds can be remunerated in their context. But nonetheless, no one knows what the right number is. And even across the country in Canada, that number is fairly variable. In BC here, we're a little bit below the average that's essentially skewed by Ontario. But clearly it's a little bit more clustered towards that mean of about 13. Strangely though, that number is not constant over time. This is also Canadian data, looking at the trends in utilization over about a 6-year period. And over this time period, you can see that the overall increase in hospitalizations is increasing, and that shouldn't surprise any of us. I mean, we know the problems we're dealing with our socio-demographic shift and our aging population. But our increase in ICU utilization is actually out of proportion to that. And this is probably multifactorial as well. And we don't really understand why this is happening. But a leading theory is that this is probably being driven largely by HAU type admissions. As more and more hospitals get these units online, not unlike our current situation at St. Paul's, these beds are being utilized. We hope appropriately, but again, we're not entirely sure. But having a full understanding of how these ICU resources are utilized in Canada is actually really important. I mean, this increase is clear. And we think that's related to our aging population, as I mentioned, but I think there's also an increasing component of case complexity playing into that too. And neither one of those problems are going away. As time goes on, our population will get older and will continue to push boundaries appropriately and expanding the repertoire of care we're providing for our patients. And that very well may require the utilization of ICU resources. But this shift does come at a cost. And I think in our context, that cost is very material. The cost of an ICU bed is approximately 3 times the cost of a ward bed. And in Canada, that looks at something around the $4,200 per day mark in a center such as ours at St. Paul's. And obviously, as time goes on, it's going to become increasingly clear that that resource is going to become strained. It will become cost prohibitive. And that obviously has implications for long-term planning in terms of identifying how many ICU beds we need and how that will change over time. But unfortunately, this is complicated by a few unknowns that are constant in our system. And the first, and I would argue the most important, is the risk of under triage. We know from several contexts, trauma is where this is best described. If we misallocate ICU resources, if we place a patient in a lower monitored setting that actually requires an ICU, there's a mortality risk associated with that. We've seen that in trauma, as I mentioned. We've seen it in sepsis. We've seen it for neurocritical care cases. And most societies, and I would agree with this, suggest that this is something that should be avoided at essentially all cost. And what that means is that our system will always have an element of over triage. Arguably, that's appropriate, but that's an additional strain on the critical care resources we have in this country. Unfortunately, also approximately 80% of the patients we admit to the ICU are unplanned. It'd be pretty frustrating to be a policymaker with that statistic. We don't know who's coming in the door on any given day. And to make matters even more complicated, larger teaching centers such as ours constantly operate at about 90% capacity. And that's certainly true with St. Paul's and most other ICUs in the lower mainland here. So planning is difficult, and this resource is constantly strained. Not only is that a challenge from an administrative perspective, it's got very real patient implications. And there's actually several of them, and I think over the course of my training, I've certainly seen all of these. First is cancellation of elective procedures. And during our COVID epidemic, we have seen lots of this actually. And this has several downstream effects on our healthcare system. We also see delays in the admission of critically ill patients, largely from the emergency department. And this has actually been looked at in several different studies, and we know this is associated with worse outcomes. The ICU is not a place where we want to, or the emerge, sorry, is not a place where we want to provide ongoing critical care. The resources there are just not available from a nursing perspective, further away from the intensivists who are trying to provide this care. Outcomes are worse in those settings. We also know that overcapacity ICUs result in early discharges of marginal patients to accommodate new admissions. Now, it certainly has been demonstrated this results in a higher number of bounce backs to the ICU, and that's something that's also associated with worse outcomes. In many institutions, there's also interfacility transfer implications, either certain full units that are geographically closer being bypassed, or units forcing to transfer patients to other institutions to make room for new admissions. And we don't really know if there is an outcome implication to these transfers. It hasn't been looked at closely enough, but certainly we know handover is a high risk time for a patient, and potentially avoiding unnecessary handover certainly has inherent advantages. Lastly here, and I actually think this one's one of the more important ones, especially for us here in St. Paul's, and that's a night discharge to the ward. We know that this is a high risk time. Any transfer of a patient is a high risk time, and staffing is definitely worse in nights, essentially in every institution that I've ever worked at. And so we take a rush physician doing transfer orders, passing off to a rush physician, receiving the patient, mistakes will happen, and this has been documented, and it's associated with adverse events. And so avoiding any of these things obviously has advantages. You can argue that any of these is actually an administrative problem, and potentially true, but I think there's very real documented patient implications to all of these. And this is just one. This is actually Canadian data that I found really interesting, looking at the risk of a change in a patient's goals of care to something that excludes ICU care, something like a DNR M3 status or a comfort care order, as a relationship to the number of ICU beds that were available in the institution. And you can see in times where there's no ICU beds available, the risk of changing somebody's goals of care doubles. Now, that's pretty impressive, right? These are conversations that are supposed to be ideally based on the patient's values, clearly being influenced by ICU resource availability. Now, this particular study wasn't powered to detect an associated mortality difference, but other studies have looked at that exact issue. This is a plot from a meta-analysis looking at the relationship between refusal of ICU care and associated mortality. And they did a couple different analyses in this study, but what they demonstrated is a 3 to 4-fold increased risk of death in patients who are denied ICU care for any reason. Now, that's not entirely surprising. We would expect there to be an outcome relationship between the decision to admit to a higher acuity setting and death. But this study was also able to look at the risk of, or at least what the patient demographics were that were admitted to the ICU when resources were a little bit more strained. And in times where resources were tight, when beds were in short supply, the patients that were being admitted to the ICU were younger and they had more severe illness compared to times where there were more beds available. And that certainly suggests that there's an inherent selection bias that we're applying when these resources are strained. And that definitely would have implications for patients that are potentially denied that care. But the implications are actually extended even further to patients that are already admitted to the ICU. This was a really interesting Danish study, actually, that looked at a 17-year period trying to identify the risk of mortality as a function of ICU occupancy. And what they were able to demonstrate is at any point in time over this 17-year period, an increase in occupancy by about 10% was associated with about a 1% increased mortality risk. So each 10% increment increased the risk of mortality further. And this data is actually a few years old now, but COVID has been actually very enlightening from a similar perspective. This is American data. This is from the VA system in the United States, actually just published in JAMA Public Health, looking at the relationship between the ICU load of COVID patients and mortality. And what they were able to demonstrate is when the ICU load increased, so did the risk of death for the patients that were admitted to that unit. You can see that when the ICU was over capacity, the risk of mortality was about 2.35-fold higher than baseline. You also see a really impressive dose-response relationship there. This relationship is real. I certainly believe it. And so deciding who to put in the ICU actually has administrative implications. It's got implications for patients that potentially need the ICU. And it has implications for patients that are already admitted to the ICU. So clearly we need to be pretty careful in terms of who we're selecting to put in these units. And the obvious question is, well, how good are we doing? And that's a really difficult thing to study. But there have been a few authors in Canada that have tried to look at how good we are, both as internists and intensivists, at predicting how well somebody is going to do. And the result is we're not that great at it. This was actually a survey-based study done in Canada where respondents were sent some detailed cases to review, cases of real patients that had real outcomes that were known to the authors. And the respondents were asked several questions, including what is the likelihood that this patient is going to survive their ICU stay, and what's the likelihood they're going to survive to hospital discharge. And it doesn't matter if you're an intensivist or an internist, our ability to predict who's going to do well or who isn't all that great. Even if you look at our ability to survive a hospital stay, we are still wrong somewhere in the realm of 25 to 30% of the time. And you can argue that that's okay. Right? Nobody is going to be perfect. We don't have a crystal ball. We can't deal with absolutes. But you'd think that we should at least be able to be consistent, or at least agree amongst ourselves at which patients might do well and which patients might not. And this study actually asked that question too. And so they were able to look at inter-rater reliability between the respondents in this particular study. Now they looked at the kappa scores, and a kappa of 0 is associated with no agreement, a kappa of 1 associated with perfect agreement. And what they demonstrated is, at best, if we're predicting survival through the ICU stay or survival to hospital discharge, at best, we're looking at mild agreement, if anything. So it becomes pretty clear that we're probably not working on the same framework, or we're not putting equal weight on the variables that we're using to make these decisions, because we're not all agreeing on who's going to do well and who isn't. So trying to be explicit about what's coming into this decision-making might be helpful to at least be a little bit more consistent in ICU patient selection. So ultimately, we have to decide who we bring into the ICU. Now, I'm not going to pretend that I know, because I don't. I honestly don't think anybody does. But throughout my entire training, I said, well, if I don't know who I'm going to bring in, I should at least know who I'm going to exclude. And that should be the patient who bringing to the ICU would be futile. And futility is kind of an interesting concept in medicine. I used to use this word a lot. And it suggests an act that is useless or ineffectual. In our context, futility refers to interventions with no possibility of a physiologic effect. Some common examples would be using something like orange juice as an anticoagulant, or performing CPR in the setting of a ruptured myocardium. These are things that don't have a chance of achieving the outcome we desire. But if we're being honest, most interventions we do in medicine have a greater than 0 probability of a physiologic effect. At least I would hope so. So what cutoff are we using to define a treatment that's futile? And is that influenced by the patient context? Is that influenced by the patient values? It becomes a little bit cloudy. And to illustrate that further, I made up 2 cases. One is a 26-year-old female that has a catastrophic traumatic brain injury, something that's clearly not survivable, or a 95-year-old male with pneumonia and an underlying advanced dementia. You know, both of these cases, you could consider ICU care to be futile. But in both cases, mechanical ventilation can provide adequate oxygenation and ventilation. Vasopressors could potentially support and organ function. And so clearly these interventions are achieving a physiologic effect. But when we use the word futile, we're really just disguising our own judgments in terms of a treatment's value for a specific patient as physiologic certainty. And I would argue that that's probably a little bit dishonest. It's deceptive to our patients and their families, and it's also deceptive to ourselves. So the word futile is probably not the appropriate word to use. I think this society's both in Canada and the United States, would agree with this. So instead, they suggest using this term, a non-beneficial treatment. And these are treatments that at least have some chance of accomplishing the effect we're looking for. But we believe that there's competing ethical or other considerations that potentially justify not providing that treatment. And these are beliefs that largely stem from our values. I think we need to be open about that. But I also think that not sharing those values is wrong, because these values are honed from our experiences and fundamentally come out to be expert opinion. And so those values and those beliefs are actually important components of our goals of care discussions. And certainly when this has been looked at, having frank conversations about what life can realistically be expected to look like during an ICU stay or afterwards can bridge many of the divides we run into over providing potentially inappropriate care. But I also wouldn't pretend that good discussions can prevent the request, at least, of non-beneficial treatment from patients or families. We see this all the time. And certainly when we remain far apart on these issues, the clinicians and families, this is often a reflection of background family dynamics or strongly held cultural beliefs of some kind. And that's likely not going to be reconcilable with modern scientific assumptions or rationale, such as a treatment being futile. And so these are often and will remain very difficult situations. But I do endorse the fact that being open about potential value of treatment, keeping in mind the patient context as well as patient values, is an important part of understanding who to include or exclude from the ICU. And we've actually looked at specific criteria to provide ICU care. And this has been looked at time and time again. There's actually over 200 studies at least that have looked at this, and they can be policy statements, or they can be society guidelines, or they can actually be primary literature, trying to identify criteria with which to exclude patients from the ICU for. The first and most common is patient preference, and I think that remains important, and that's another plug for thorough goals of care discussions with these patients. About 70% of patients that are ultimately excluded from ICU after ICU referral are excluded for reasons of preference. The second most common is functional status, which is obviously fairly closely related to age, but definitely not the same thing. Those two things together combine about 80% of the reasons for ICU refusal. Lack of social support is something that is used from time to time, but that's usually for things like transplantation consideration. Other condition-related factors such as persistent vegetative states or advanced cancer with no further oncologic treatment options, patients that are too well or too sick. It's a common frustration for everybody, I'm sure. And patients with high SOFA scores, metastatic malignant disease, or irreversible neurologic disease. These are all things that are commonly cited as reasons to exclude someone from the ICU. But not one of these things on its own is useful as a criteria outside of patient preference. And just to illustrate some of the data looking at these things, the first is age. And certainly over the past 5 to 10 years or so, we have become more comfortable with the fact that age on its own is not a good surrogate to predict outcome following essentially any treatment. And the ICU is no different. This is American data, but Canadian data is very similar, looking at the risk of ICU mortality associated with age. And even if you look at the patients that are over 90 and admitted to an ICU, and granted, this is a selected population, the risk of mortality is about 30%. That compares to our baseline mortality risk of somewhere in the 20% range, right? So certainly this is helpful, right? It's certainly useful for informing patient discussions, but I think we could all agree that excluding someone from the ICU based on age alone is not a reasonable thing to do. And that is underlied the concept of frailty. And I think this is probably a far more useful concept. This is just an infographic looking at the frailty score, which is a very useful foot of the bed scoring system to identify patients with significant frailty. Moribund patients, patients with a frailty score of 9, they're approaching the end of their life. I think we could all agree that that's probably a patient that should be excluded from the ICU. But then we have this middle ground, these patients that are very severely frail or moderately frail. And it becomes a little bit less clear what to do with that patient population. This is also Canadian data. And it shows a couple of actually really useful relationships. The first is the relationship between frailty and mortality going into the ICU. And you can see there's a very clear relationship, and this relationship is much more robust than the relationship between age and mortality. If you look at our most frail patients, their risk of death in the ICU approaches 80%. It's very useful. But if you look at our people with frailty scores of 6, 7, and 8, their risk of mortality is really in the 50 to 60% range. Again, although that's very useful for sitting down and having a conversation with the patient and their family, it's again not particularly useful for making admission decisions based on this exclusive information. The other interesting thing about this study is they stratify based on acute admissions and elective admissions. And it's very easy to say that patients who are admitted to the ICU electively, and this would typically be a patient following a surgery, cardiac intervention as well, people that need advanced monitoring, at least acutely, they do much better. They are clearly different populations and need to be thought of differently because it's very clear that their outcomes are substantially better. And this is probably because this is a more highly selected patient group initially. Malignancy is another tricky one that we often quote as a reason to exclude someone from the ICU, potentially. Now, this is data from Europe on patients with hematologic malignancies. Now, bit of a busy graph, but what you can see is on the far left of each of these panes is day 1 of ICU. And this is close to the day where we would be making a decision whether or not to admit a patient to the unit. And even at this time, if somebody with cancer, a hematologic malignancy requires mechanical ventilation, requires vasoactive drugs, or even requires dialysis for some reason, their mortality is kind of in the 40% range for ventilation or vasoactive drugs, and even lower than that if they require dialysis. Again, useful. Again, this is a marker for potentially worse outcome, but also not useful for making admission or triage decisions based on exclusively. And finally, SOFA score, probably one of the most common mortality prediction models that we use based on real physiologic parameters. Even patients with a very significantly elevated SOFA scores in the 11 and 12 range, their mortality following an ICU stay, in this one study anyway, was kind of in the realm of 50 to 60%. So every single one of these criteria, whether it's age, frailty, underlying diagnosis, or physiologic parameters, they are useful for informing these decisions. But they are also not useful for making admission decisions based on exclusively. And again, this is probably because this is a more highly selected patient group initially. but each one of them on their own is not particularly helpful. And obviously, authors have tried permutations and combinations of things like this to try to identify an algorithm for which we can identify a patient that is or is not going to do well following an ICU stay. Over the course of preparing this talk, I was able to find 43 different ones, and I'm sure there's more. Now, all of them are different. Some are easier to use than others. They all have various levels of internal and external validation. But what's true with all of them is that there's no universal agreement on a probability cutoff where a treatment can be considered non-beneficial. And additionally, every single one of these studies is epidemiologic. None of them are randomized, and none of them have follow-up following the application of a mortality prediction model. So not a single one of them is useful for individual patient application. Certainly useful for planning, certainly potentially useful to guide discussions with patients, but not possible to exclude a patient from the ICU based exclusively on any one of these. And I would argue we're probably never going to have a prediction model that we can use to identify the ICU patient. It's almost asinine to think we could, right? That's not how we make decisions in medicine. But there has been a push to try to identify tools that can be used in the trenches to find an ICU patient, or at least guide the discussion towards potentially including or excluding a patient from the ICU. And one group in South America developed an ICU admission decision aid tool. And what's interesting about this tool is it was essentially just a referral form that had 3 questions that the ICU or the referring physician was required to complete prior to submitting the referral. And the 3 questions were really simple. The first was, why do they need ICU? Is the referral for monitoring, or is it for an intervention? The second question was forcing the referring doctor to be explicit about the stage of the previous disease of the patient. And the last question was, what's the patient's underlying functional status at baseline? And the interesting thing about this decision aid tool is it had nothing in it about the diagnosis of the patient, nor did it have anything in it about physiologic variables potentially necessitating ICU, such as blood pressure or FiO2. And what they are hoping to do is potentially identify patients that weren't suitable for ICU and exclude them. And what they hope to essentially do is exclude patients with a priority level 5. Now, this is a grading scale that comes out of the United States from the Academy of Critical Care Medicine. And what it is essentially identifying different priorities of patients to admit to the ICU. A priority level 5 is a terminal patient that doesn't have any possibility of recovery. I think it's fair to say that this is a patient that we would want to exclude from the ICU environment. But I think it's also fair to say that this is a patient that from time to time does end up getting admitted to our units. And what these authors were able to demonstrate was that when they use this tool in a before and after ecological sort of study design, they decreased the priority 5 admissions to the ICU by about half, simply by forcing us to take a step back and be explicit about the reason for ICU and what the patient's underlying physiology is like from a previous disease and functional status perspective. So fairly useful. But practically speaking, we do need specific criteria that we can use to try to identify patients that are going to be suitable candidates. As our resources become more and more restricted, this is going to become increasingly important. And I think the specific qualities of those criteria are pretty important. They need to be specific. They certainly need to be scientifically sound. And by that, I mean there needs to be an association between the criteria we're using and an outcome that we're interested in, being mortality or quality of life. They need to be measurable, they need to be feasible, and they need to be user-friendly. They need to be usable, something that we can rapidly apply when we're deciding who to refer. And I would argue all of these need to be true because we need to be able to be consistent and reproducible in how we apply these criteria. And there hasn't been a lot of effort to develop criteria like these for some time. But again, we can thank COVID for forcing us to take pause and recognize that our ICU resources are in fact very constrained. And so there was actually a large movement during the course of this pandemic to develop triage guidelines to help us identify which patients we may need to exclude from the ICU if we physically run out of capacity. Something that became a real possibility at several points in time during the course of the pandemic. And although I hope most of that is behind us now, I think these lessons are very real. And so every jurisdiction in this country started to try to develop a triage guideline, at least, that could help hospitals and institutions triage the critical care resources in a justifiable or at least equitable way. And Ontario actually put out one that I quite liked. And this is what theirs looked like. They had 3 different triage levels. Now, importantly, the physicians caring for the patients were not the ones responsible for deciding what level we were in. This comes from an institutional place, an administrative place. And each triage level aimed to exclude patients with a different level of predicted mortality. The first triage level hoped to exclude patients with a greater than 80% predicted mortality. Triage level 2, patients with a greater than 50% predicted mortality. And triage level 3, if things got really, really tight, patients with a greater than 30% chance of predicted mortality. And these are the criteria that they use, and each one of them is very specific, it's very measurable, it's very feasible, and it's very usable, right? So a severe trauma with a TRIS score that predicted greater than 80% mortality, that is very straightforward to calculate. Severe burns in older patients, cardiac arrests that are either unwitnessed or non-shockable, severe baseline cognitive impairment, advanced irreversible neurodegenerative conditions, poor functional status in the setting of advanced metastatic disease, all things that are quite easy to identify very quickly. And as we transition up the levels, we become more and more strict in terms of who we're trying to exclude from the ICU. Now, this guideline is definitely easy to use from our perspective, but I actually think the power of this guideline is the fact that it was publicly available. So this is pulled off of Ontario Health's website. This was explicit, this was transparent, and the public was informed. And I think if we're talking about potentially restricting our resources, in a public healthcare system, we really do need to involve the public in that process. And so what I liked most about this guideline is it attempted to do that. It made the public actually recognize that this resource is not infinite and we might have to make some tough choices. And this is how we're planning on doing it if it comes to that. And I really don't think this guideline was actually implemented in any significant way. But I think the fact that we went through the process to generate it is actually a really important lesson that needs to trickle down to other areas of critical care. So the ethicists have obviously weighed in on this. And to be honest, the best statement from the ethicists came out of the United States about 20 years ago, kind of in the mid-90s. And they essentially identified 7 important points when we're trying to triage critical care patients. And I actually really like all of these criteria. And so going through them, the first thing that they said was that providers, people initiating ICU referrals, need to advocate for the patients. It's the job of the patient physician who's contacting ICU to advocate if they feel like critical care could provide benefit to their patient. At the time that that referral is initiated, the person making the referral knows far more about the patient than the intensivist picking up the phone. So advocacy remains an important part of this process. There's no question. Secondly, members of the provider team, be it the intensivist or the referring physician, should collaborate. And I also think that that's an important point, because I think sometimes the referral process seems to end up being somewhat adversarial. And I think being very cognizant about that is important, because this is a collaborative process, ultimately. Trying to identify an appropriate ICU referral takes multiple physicians from time to time. Thirdly, care in an equitable system needs to be restricted. COVID has made us more and more comfortable with this. But that being said, I don't think we often think that we're in a system that's as constrained as it actually is. And so I think the public, as well as us, have to be comfortable with the fact that ICU resources are finite, and we will be in situations in the future where we're going to have to say no to patients. Next, the decisions to give care need to be based on expected benefit. And really, they should probably not ever be based on anything else. The ICU resource needs to be there for patients that can benefit from that resource. And I admit that identifying that patient is difficult, but as long as we're going into the decisions with that in mind, is probably the most justifiable way to approach this. Mechanisms of alternative care should be planned. And in our system these days, there are other mechanisms, right? We have a high acuity unit available to us now. We have an outreach team available to us now. There's telemetry units available. There are other levels of care outside of the ICU proper that could potentially benefit for a patient. And when a patient is refused from the ICU for any reason, that should not be a yes or no process. That should be a mutual decision on an alternative care plan. Now, this one's particularly important, and that's explicit policies need to be written. And I think we're going to be pushed to do this more and more as time goes on. And finally, after we write those explicit policies, prior public notification is necessary, because I think as soon as patients feel like they are being treated unfairly for any reason, they're going to lose trust in us. And I think one of the easiest ways to potentially avoid that is by being very, very transparent about any triage process that we use. And I'm not pretending that that's easy. I'm just pretending that I'm just suggesting that that's going to be really important. So with all that being said, I just want to leave you with a few take-home messages, and then there's going to be some time for some discussion. Looking forward to that. And the first thing that I think needs to be absolutely clear is that critical care is a finite resource. And our COVID challenges have reinforced that very strongly. Our admission decisions also influence the outcomes of other critically ill patients. Those are patients that are in the ICU presently, as well as patients outside of the ICU that potentially need to come in. There's a gravity to the decision to admit patient to critical care. And finally, the decision to ultimately provide critical care needs to be made collaboratively. And it also needs to be based on what our current resource availability looks like, which means it's going to be a dynamic process. And that's something I think all of us need to be comfortable with. So that's really what I wanted to talk to you guys about. And I thank you so much for the opportunity to chat. And I'm more than happy to take any questions or comments you guys might have.
Gavin, thank you for the really thought-provoking and excellent presentation of a very complex and persistent and ever-increasing problem. Certainly, Yeah, there's probably, I'll just check the chat box. So it says, hi, the St. Paul's team is all there. Unfortunately, they don't have video. So there's nothing else in the chat box. Any questions for Gavin?
Gavin, it's Keith Wally. I really enjoyed that. Thank you. Very thought-provoking. I noticed, for example, the Ontario guidelines and other things that you look at all deal with expected benefit. But I watch TV with those commercials about new drugs where, you know, they're falling in love and gonna dance in the moonlight and stuff like that. But I noticed at the end of the commercial, they talk really fast and tell you all the bad stuff. I wonder if we should be thinking a bit more about informing our patients and families about the bad things so that in the end, they feel like they've made a decision. And so, for example, when you stick someone on mechanical ventilation, maybe all we tell them is we say this will help their breathing and keep them alive. But maybe we should also tell them it's really uncomfortable. It leads to poor sleep and delirium. If you become delirious, we will tie you to the bed, effectively handcuffing you, hands and feet to the bed. You will almost certainly develop PTSD so that you will have night terrors and day terrors for months or longer afterwards. You will likely get an infection of your lungs and die of some god-awful infection. There for sure will be some degree of lung damage, which could be chronic and last for your lifetime. And for sure, there will be extreme muscle deterioration. So you will be incredibly weak for weeks, months, or years afterwards. I wonder if we told them that stuff, if they would pause and think a little bit about balancing risk and benefit instead of us just restricting access to benefit.
I think that's a very fair point, Keith, and fundamentally comes down to how an individual interprets risk, right? And I don't even know how I interpret risk. What I think I would want to know coming into an ICU stay is what it's going to look like and what it's going to feel like. And I totally agree with you. I think we're really bad at painting that picture. You know, we're good at talking about numbers of predicted mortality, et cetera, but it doesn't really mean anything, not to the individual anyway. I think what individuals want to know is, well, how is this going to make me feel and what am I going to look like at the end of it? And I think until we're able to adequately illustrate that picture, I think you're absolutely right. People can't really make informed decisions. And it's one of the frustrations. And I don't know what the right answer is in terms of how to give them that information. But it's certainly going to be an important part of these discussions going forward. There's no question.
Any other questions for Gavin?
Can I maybe ask a question, Stefan Van Eden here? Did you look at what is the impact of patients? Because a lot of these patients that end up in the ICU as chronic underlying diseases. And what is the impact of how many of those patients this whole scenario was discussed beforehand by their GP or their family physician or whatever? And how does that influence your, in the end, what the patient decide they want? Because I think that that actually may have a very big impact on, you know, a more rational decision when you get to that point where you need to be admitted to the ICU. Did people look at that to see if GPs talk with their patients about this, or specialists that treat chronic diseases?
No, absolutely. And it's been looked at in a couple of different ways. And what we've learned is that those discussions are helpful. We've also learned that those discussions don't happen often enough. And this has been looked at most closely in the oncology patients. You know, a good goals of care discussion over the course of oncology has been very helpful in terms of identifying patients that ICU care would be outside of their preferences. But the frequency with which those conversations happen is actually far lower than one would hope. And I do think that the outpatient setting is the perfect place to initiate these discussions. And certainly from our own experiences in the ICUs, it doesn't happen nearly often enough.
I have a question, Gavin, and it's related, but the inter-rater appreciation of the guidelines, has that been looked at? I mean, so you can set a set of principles or guidelines, but the interpretation on an individual basis by a specific physician, in my experience, it's often that's a very big variability. Can you comment on that?
Certainly, and that's a very insightful point, Dr. Kassan. And in short, it hasn't been looked at in any detailed way, but it has been identified by several of the societies as a big knowledge gap. So all of these guidelines or mortality prediction models, essentially not one of them has been studied prospectively in the sense of how good are these when they're applied to identifying potentially bad ICU candidates, or how accurately they're applied by physicians. And that very thing was actually identified by the Society of Critical Care Medicine as a big knowledge gap that needs to be addressed when they put out their policy statement in late 2020. Certainly needs to happen.
Yeah, the bias of the individual physician often, so Keith has provided a really good description of what the potentials are by being ventilated. But we could equally say, you know, I'm a surgeon, I really don't know what's wrong with you, so I'm going to slit you open, slit your abdomen open and pull your guts out and mess it and put my hand in here and look here. I could rupture the spleen. I could tear the bowel. Maybe you'll bleed. Maybe I'll put a stitch in the wrong place. When would you like surgery? So, I mean, I think it's in the framing and the presentation. It's not just the information.
No, you're absolutely right. That sounded a lot like most of the consent processes I go through, actually.
Any other comments or questions for Gavin? If not, thank you for a very, it's actually a wonderful presentation and a great topic, and more clarity than I think I've had before, but certainly a stepping stone to the next steps for all of us. So thank you.
Thank you. Agree.
Thank you so much, guys. Take care.